What do you usually do? Do you usually sign in here?
We're still waiting for folks to join the call, but just so everyone knows, I did start recording. And we'll ask if you can please put your name, where you work, and your email in the chat box to help with attendance.
I should type stuff in. Get the credit card. I want to see you, I would think. Well, then they put everything on the slide. So.
We'll give it another couple minutes and see if anybody else joins before we start.
Yes, please, yes.
We'll go ahead and get started for the sake of time since we're a couple minutes after 3. This is Heather Drake talking right now from Maine Cancer Foundation. I'm a program manager here and help facilitate the Project Echo Call. So thank you everyone for joining us this afternoon. Today's topic will be on palliative care, and after we go through introductions, we'll hear from Dr. Lauren Michalakes, who will be presenting our didactic presentation, and then Kim Danforth, who will be doing our case study. And then we'll open it up to general discussion about palliative care after that. Just some reminders. I don't have my slides up, so I'll share those. But please, we encourage everybody to use video if that's an option, and you can do that from your computer. We also ask that you type in your name, your organization, and your email into the chat box so that we can just have a little more help with our record keeping and making sure that we have everybody documented for our attendance. It will remind you all that we are recording the session, So it does record the video, any of the chats, but if you do chat with anyone privately, it doesn't record that. A reminder to never disclose protected health information. We want this to be an open dialogue today, so please feel free at the end of the presentation and at the end of the case study to join in with any questions or comments that you might have about the topic. A reminder to speak loudly and clearly, and hopefully everyone can hear us here at Maine Cancer Foundation, but if you can't, either shout out and let us know or type it in the chat box. Aisha is helping us with any administrative questions or troubleshooting, and she's listed as the MCF administrator, so you could just chat her directly if you want to. And just a reminder that if you are using video, we can see you. So just a reminder about that. So I will kick it over, sorry, we forgot to do introductions. We'll go ahead and do introductions first, and then I'll kick it over to Lauren for the presentation. So Beth Ann, would you like to start?
Sure. My name is Beth, and I'm a patient navigator with Northern Lights, the Best of Cook Valley Hospitals, and I've been doing this job since December of 2016.
Great, thanks for being here.
Thank you.
Barb, would you like to go next? All right, we'll wait on her. How about Heather? Oh, Heather Sinclair. Is everybody still able to hear us?
Hi, I'm sorry, I was having technical difficulties. My name's Heather Sinclair. We're at MDI Hospital for the Navigator program and our palliative care program.
Great, welcome. And Cherry Lynn, would you like to go next? It does look like you're muted. Okay, we can circle back to you in a second. And then we have Heather Stevens. So it doesn't look like you're muted. I'm not sure why we can't hear you. But anyway, Heather is from the Harold Alphon Center for Cancer Care, and Cherry Lynn is from Dartmouth Hitchcock. And then Lauren, do you want to introduce you and Kim next?
Sure. This is Lauren Michalakes. I'm the palliative care doctor up here at Penn Bay and also at Waldo and in palliative care. And Kim, you can introduce yourself.
I'm in here. Hi, guys. I'm Kim Danforth. I'm the oncology navigator here at Penn Bay.
Hi. Welcome. Is there anybody else on the call?
Hey, good afternoon. It's Sherilyn. Sorry. Yeah, I'm the nurse navigator from Dartmouth Hitchcock, and I think I've met some of you at the conference at NACOS last week. Hi, Aisha.
Oh, that's great.
Hi,
Yeah.
Sherry. Nice to hear your voice again. This is Aisha.
Thank you.
Hi there, and it's Magda Alden, American Cancer Society Patient Navigator at Maine Med in Scarborough.
Hello, welcome. Is there anybody else on the phone? Okay, and it did look like Robin from New England Cancer Specialist was in and out, so she might be back, but we can do introductions in the room.
I'm Caitlin Michaud from Maine Cancer Foundation. I'm a program manager here focused on grant making, and I'll be helping take some notes today.
And hi, my name is Aisha Sheikh. I'm the Director of Programming here at Maine Cancer Foundation, and I will be managing the chat box and helping with technology.
Thanks. And just one last call. Is there anybody else who we missed on the phone?
Carrie is here with Heather Stevens, Carrie Medeiros and Heather Stevens at the Harold Alphon Center for Cancer Care, and we're trying to connect online as well, but having difficulty on our end.
Okay. Well, if we can help in any way, let us know, but thank you for calling in.
Sure.
All right, well, we'll go ahead, Lauren, if you're ready. I'll pull up your slides and we can get started.
I can't. Oh, I can now.
Okay. That's good. How do I get everything off over here? Never mind. Okay. All right, guys. Well, thank you for inviting me to speak today about palliative care. You know, I'm assuming that I know a lot of this group works with palliative care every day and understands what palliative care is, but I think it's nice to have an opportunity to sort of sit down and talk about it in both a structured and an informal way as offered by ECHO. So thank you so much. What we're going to try and do today is really describe palliative care, define palliative care as an interdisciplinary approach to the care of patients with serious illness like cancer. I think it's always a good idea just to sort of separate out what do we mean by hospice care as a separate entity within palliative care. It's delivered in a very pure way, and fortunately it's reimbursed for the most part under the Medicare hospice benefit, which is a lovely thing if you understand it. And then we just want to talk a little bit about, you know, the imperative for blending palliative care with oncology. There's a certain aspect of quality and value added features of palliative care as a patient lives with a serious illness like cancer. And, you know, cancer has been sort of the forefront of data in palliative care with regard to demonstrating that there is definitely value added. So we'll spend a little time talking about that. Next. Okay, so just a very dry definition of palliative care. It's a medical subspecialty called palliative medicine within the bigger construct of palliative care. It is specialized medical care for people living with serious illnesses. It focuses on providing relief from symptoms and the stress of a serious illness. The goal is to improve quality of life for both patient and family. And this is a challenging part for many of us in rural programs. Palliative care is ideally provided by a team of palliative care clinicians, including doctors, nurses, social workers, and chaplains. You know, if you work in a large place, perhaps you're lucky enough to have a dedicated team of doctors, nurses, social workers, chaplains, and others who work together. Here in Pembe and Waldo, you know, I'm a palliative care physician, but I don't have a dedicated social worker. So what you find yourself doing is sort of creating virtual interdisciplinary teams based on where the patient is. If a patient is in the hospital, I can find a social worker, and hopefully he or she has expertise in the elements of palliative care, and the same for, you know, chaplains and other professionals. The important thing about palliative care is that we work within that team structure. We work with the primary team of oncologists, perhaps, to provide an extra layer of support. And that phrase has kind of become very important to our field, like when we try and define what it is. We're an extra layer of support for patients and families living with life-limiting illness. And it's appropriate at any age, at any stage in a serious illness, and it can absolutely be provided in parallel with curative treatment. Okay, again, that's not true for hospice necessarily, but it's definitely true for the broader definition, which is palliative care. Next slide. So this top panel, you can press again because it'll pop. Yeah, perfect. I love dancing slides. So this top part, rectangle is really kind of the old paradigm regarding palliative care. So if you look at you know, the far left side of the box where it's all blue, and that's the time when a patient is initially diagnosed with their life-limiting illness, like an incurable cancer. Then they move along the trajectory to the right. And in that box, they receive all of their life-prolonging, disease-modifying treatments, such as chemotherapy and radiation, antibiotics, blood products. And then they reach that line, that black line after that arrow over on the right. where it's kind of a magic line where people two doctors decide that the patient is terminal, and then the patient can jump into that little green box, which is the Medicare hospice box, and receive lots of interventions to support physical, emotional, social, spiritual distress. As opposed to the bottom diagram, which is more the ideal, that as soon as a patient is diagnosed with that life-limiting illness, certainly the top blue part implies that most of the interventions are going to be directed at life-prolonging and disease-curing. But as time goes on, in the face of incurable illness, there is the opportunity to start interweaving palliative care interventions. There's patients who, as they receive their cancer treatment, have questions, have concerns, have pain, have fear, have worries, and why not start addressing those things even now by an extra layer of support, an additional set of clinicians who are skilled and helpful in the treatment of those types of distresses. And then you notice that there's still that magic line. Interesting that the magic line comes maybe a little bit sooner than the top box. It's not always true, but ideally perhaps, that as people really define their goals of care and define what matters most, they may jump into a purely comfort or a hospice plan of care even sooner and live well during that time. It's more the ideal that as soon as people start to hurt, start to have suffering, let's find ways to work together to provide some relief. So that's, again, the ideal. Next slide. And then of course, there's like the reality, which nothing in life is linear, right? The squiggly line is meant to imply that it's not a straight line, like, one day, there's sort of like equal or predictable measures of how many of the interventions applied are palliative and how many are not. Sometimes we see patients very early in the course of a eventually life-limiting illness that is not curable, but the patient still has time. Well, we make it involved early if there's a lot of pain involved, and then we'll kind of step away, and patients will receive their first and second and maybe third lines of chemotherapy. And as things don't work out, then we will become involved in a more intensive fashion. So this is meant to imply that the delivery of both disease-directed therapies in balance of palliative directed interventions and therapies will be determined by what the patient needs at any given moment. And then at the end of this particular trajectory, patients have the opportunity to go to hospice as before if they're terminal, or I like this slide where they talk about, maybe sometimes people live, right? Sometimes people survive for longer periods of time or in prolonged remissions, and may even be defined in a period of living well in survivorship. Okay, next slide. So hospice versus palliative care. Left is hospice and right is definite palliative care. So we all kind of started in hospice. Hospice has been around since the late 1970s, early 80s. It is a Part A Medicare benefit. Medicare wrote reimbursement into federal law in about 1982, allowing for predominantly home-based services to support the care of patients at the end of life, such that they could stay at home in response to what was happening in those earlier decades with an over-medicalized death, and especially in cancer patients. Since those days, we've expanded hospice to include patients dying of other diseases like heart failure, COPD, and dementia, for example. But suffice it to say that when it was written in the early 80s, it was predominantly for the cancer patient that really needed another way out of some of the painful dying that was happening in those days. It is comfort care. It's predominantly comfort care. Very little disease-specific treatment is delivered in hospice care. So one of the barriers is, many of our cancer patients still receiving radiation therapy, even if it's with a palliative intent. Many times those patients are just not able to get into a hospice program because of the reimbursement mechanism. Once a patient gets into hospice, all treatments related to that life-limiting illness would need to be paid by the hospice program, and there's no way that our small hospice programs in a small state like Maine can really take that on. Most care delivered is in the home. There are allowances for general inpatient levels of care when there are predominantly symptom management issues and respite. And we have a couple of hospice houses in the state. There's one in Scarborough, one in Lewiston, and we have one here in Rockport. And I think is there another one up in up north? I think there might be. As opposed to palliative care, there is no formal and identified reimbursement mechanism for palliative care, with the exception of what a physician can bill for under Part B. Like I said, it's supposed to be delivered in a team with nurses and social workers and chaplains, but the only person who gets paid on that team is the physician or the nurse practitioner. So it's a real problem. So that's one bad thing, but it can be delivered regardless of prognosis. So a patient who's in the midst of aggressive treatment for advanced cancer, even if the prognosis is in the range of months to years, we can see that patient. Even if the patient is predominantly felt to be curable, we can see those patients if there are significant symptom issues or if there are some coping issues that we can be helpful with. And again, can be delivered concurrent with disease-modifying treatment. We frequently see those patients in sort of a pre-hospice sort of framework as radiation, palliative chemo is sort of coming to a close. We frequently see those patients and help manage that transition into the hospice program. And we can deliver palliative care everywhere. Up here in the coastal area, we see patients in the hospital, in the cancer center, right here where we are. We see patients in their homes. We see patients in the ambulatory clinics with the primary care docs. We see patients in nursing homes, and we see patients actually in their homes. And there's no real limitations as to where we can go, just our own inabilities to be in more than one place at once. So, next. What do palliative care clinicians do? I think it's, even though people may have a pretty good idea of what palliative care might be in theory, but what happens when we close the door? What do we do? Do we immediately talk about death? Do we immediately go to the end of life scenarios? Well, we don't. Especially as we see more cancer patients early on, we have to be really careful that we're not providing a mixed signal. As a patient with advanced cancer gets seen by our oncologists here and are sort of working together to create a plan of chemotherapy and radiation, that provides patients and families with some hope. And then they say, oh, and we want you to see palliative care too. We have to be real careful that message is one of maintaining hope and support and not being equated with this idea that this disease is eventually life-limiting. So our first engagements with patients tend to be very kind of high level in terms of how are things going? This must be so very hard. Tell me what you're thinking. And what did Dr. Conley, the oncologist, tell you? And so what do you think? And you do kind of eventually find your place in deep and sad places, but the whole skilled encounter really is on trying to find ways to redefine and recreate hope. We do comprehensive assessments in physical, functional, emotional, and social and spiritual domains. There's not just one type of pain in these people. Hearts hurt and minds hurt, families hurt. It's always easy to get in and define your usefulness if there's some pain management issues that we can be helpful with. It's always important for us to explore support, coping mechanisms, emotional, spiritual issues. You always want to know who's in the room with you to help support this patient as future challenges arise with the trajectory of illness. We work in an interdisciplinary fashion with other disciplines. We work with physicians, the oncologists, the primary care physicians, APPs, nurses, social workers, and chaplain. A big part of what we do is advanced care planning and a higher level conversation called the goals of care conversation. We've learned a lot about the components of these conversations over the years. They're not easy. I think everyone struggles with how to do them well. So we would say that we've studied hard on what the best way to have these conversations would be, and we think we can be helpful to the team and helping to define what's the best outcome for this patient and family. And again, the additional layer of support, we represent an additional set of relationships to support the patient and family as they navigate treatment options. I often sort of describe what we do as a lens. You know, as the oncologists are so busy in prescribing chemotherapy, managing, monitoring the impact of those treatments, many times they can lose sight of what's most important for the patient. And sometimes we can look at the whole situation through a lens that is a little bit different in its focus. Okay, anything in the chat or any questions at this point? Any comments? Okay. So I mentioned at the onset that cancer kind of gets the credit for being the field that has given our specialty most support. This is an article from 2010. It's already a little old, but it hasn't changed too much in terms of its context. This was an article that was published out of MGH, out of Mass General, called Early Palliative Care for Patients with Metastatic Non-Small Cell Lung Cancer. And basically what they did is there were 150 patients all diagnosed with advanced stage 3B and 4 lung cancer, who by definition, again in those days, would have been in the early 2000s. Those patients had a prognosis that was in the range of a year or less. So what they did is they took half those patients and just subjected them to traditional oncology care with chemotherapy and radiation. The other 75 patients were treated the same way, but were also assigned a palliative care clinician very, very early in the course of their treatment and exposure to cancer treatment. And here's a conclusion box here. I'll break it down a little bit more in the next slide. It says, among patients with metastatic non-small cell lung cancer, early palliative care led to significant improvement in both quality of life and mood. And compared with patients receiving standard care, patients receiving early palliative care had less aggressive care at the end of life, but longer survival. Next slide. So again, compared to usual care, palliative care patients were observed to have improved quality of life, fewer depressive symptoms, fewer burdensome treatments. And the interesting thing is that they also lived a little bit longer. I'm sure they looked at this data hoping that they wouldn't die any quicker, right? Hoping. And then surprise, surprise, they actually lived longer, such that if this was a drug, a super yabba dabba drug that, took a life expectancy prognosis from 8.9 months to 11.6, that would be a very dramatic event in the oncology world. But this is interesting in that it's really just, the intervention is really just goals of care conversation, matching what's realistic with what patients want, and it results in improved outcomes for this very sick patient population. Okay, next. This is kind of one of my favorite articles right now, which it's not necessarily just a cancer patient article, but it has a lot to do with the implications of the first article. It's the impact of a home-based palliative care program in an accountable care organization. You're probably familiar with that accountable care organization. It's this, something under the Affordable Care Act, in that care is delivered in a very efficient way by an organization, and payment for that care is based on some quality expectations and outcomes. And then there's a cost savings that is beneficial, that's shared back with the treating organization. So it's all about value-based reimbursement. You probably hear about value-based healthcare a lot. So value is quality over money spent. So what has evolved is that palliative care has been shown to be very favorable in that quality equation, and that we do improve quality by improving patient satisfaction, improving depression and anxiety scores, improving transitions to quality end-of-life options like hospice, and then also at a lower cost. So the cost per patient during the final 3 months of life was $12,000 lower with palliative care compared to usual care in this particular article that described a home-based palliative care program. And again, a lot of these patients had cancer, but not all. So if you sort of connect a palliative care team in a home-based model, sending all these professionals into the patient's home to establish goals of care, do effective goal planning, care planning, you can actually demonstrate some really beneficial cost savings to the mix. Palliative care reduced hospital admissions by 34%. Cost savings were $2,100 per member per month for those who didn't die. So even the ones who died, they saved a lot of money. For the ones who are still living, they also continued to save revenue while maintaining quality. Next slide. So palliative care improves care. It's better care, and it also comes at a lower cost. You know, I think that when palliative care talks too much about its ability to save money, I think that's always a dangerous place to be. We try really hard not to say that first. You know, most importantly, palliative care improves quality of life, decreases anxiety and depression. It's associated with less fetal care at end of life, higher utilization of hospice. Palliative care is associated with less ED visits, less hospital days, less readmissions, and patients don't want to be there, so that's definitely a good thing. And interestingly, sometimes palliative care can improve survival. And then, you know, it's better care, and guess what? It's cheaper care. Saves as much as $6,000 to $8,000 per cancer patient, especially when it's started early and concurrently in the care of patients with advanced cancer. Next. Almost done here, guys. The last thing I wanted to just point out to you is that, again, the data is springing from oncology, and the oncologists have been first to recognize the value of palliative care in the care of their patients, and actually have adopted and created palliative care guidelines for the care of their patients. And on the left, we see just the title page from an article, Palliative Care version 1.216. I think it was a follow-up to some guidelines from 2012. These are guidelines written by the NCCN, which recommend, again, early adoption and integration of palliative care into the care of patients with advanced cancer. And then on the right side, the integration of palliative care into standard oncology care from ASCO. Okay, so both of our professional organizations who direct the care of cancer patients have made strong statements that the best care for cancer patients includes early integration of palliative care. Next slide. So this is a little fuzzy, bear with me. This is just, I just, sniffed the section of the guidelines, the NCCN guidelines, that I thought would be maybe helpful to navigators as you start thinking about who should see palliative care. Besides everybody who's got advanced cancer, how would you maybe prioritize? Because you know what, it is hard to get these patients to every place they need to go. It's really busy being a patient. You know, they've got to get to their radiation oncologist, their radiation treatment, the surgeon for their reports, their PET scan on Tuesdays. I mean, they're just incredibly busy. So how do you prioritize where palliative care might be most important? The primary oncology team should screen all patients at every visit for one or more of the following. Number one, unmanaged symptoms. That's kind of an easy one. I think, your oncologists do incredible jobs with symptom management, but sometimes, sometimes we can spend a little more time with that. Moderate to severe distress related to the cancer diagnosis and therapy. Again, this just rocks people's world, and helping people cope, or helping people sort of who feel that all their hope has been sort of destroyed, helping people resurrect and redefine new definitions of hope is something that I think our conversations can be helpful with. We're all about goals and hope. Serious comorbid psychiatric, physical, psychosocial conditions. The patients who have a long-standing history of depression, the patients who have coexistent COPD and CHF, people who have no one to love them, people who live alone. We can sometimes be helpful there. Like I said, we're moving to this place where I think we're trying to be more and more nimble. So as we try not to isolate ourselves to just the inpatient and ambulatory clinic setting, we're trying to get into these homes and try and be much more helpful and try and identifying what those psychosocial stresses are. Life expectancy of 6 months or less. Again, that would be a hospice patient, although a lot of the newer immune agents are keeping people in active treatment plans, even within that 6-month prognosis. Metastatic solid tumors, again, those are all your stage 4 cancers who certainly have a prognosis that's limited. Patient and family concerns about the course of disease and decision making. Sometimes people just need to sit down and try and process everything that's been said in the oncologist's conversations. And I love doing co-visits with our oncologists when that allows, because there's a certain way that an oncologist speaks, and there's a certain way that a palliative care clinician speaks, understanding that the material is basically the same. So sometimes we can be helpful in communicating with those patients and families who might not quite understand how quickly things are happening. And sometimes there's patients who are extremely informed, families who are informed. I read about that palliative care thing. I want that. I heard that people do better and that they live longer, blah, blah. We want that. So anyone who wants to sit with us in a palliative care encounter, we're happy to have that. So again, that's the screening section of the NCCN guidelines that I just wanted to share with you. And I sent copies of the actual articles to Heather. And I think we share slides, do we? I think we'll send the slides out to everybody who participates, and we'll make it
tomorrow.
Okay, and then we'll make sure you get copies of the 2 articles containing both NCCN and ASCO guidelines. Great. Any questions?
Does anybody have questions right now for Lauren? If not, we can send it over to Kim for the case study and then have a discussion with the last few minutes.
So full disclosure, Kim was a very generous and lovely participant this morning when I think Heather, you emailed me and said you didn't have a case. Can you find one?
Yes.
So I found Kim. So
yes, thank you so very much.
So this may just be a discussion. Do you have?
Yeah, I'm sorry, I don't have any slides. You guys will just have to listen to me. And also, sort of at the last minute, I was thinking, probably the point was to discuss a case pertaining to navigation and palliative care, but that wasn't the one that I thought of. So I don't have that either.
That's okay.
That's Dr. Michalakes is telling me that's fine. But yes, I was just thinking of, yeah, thank you. So I just had thought of a case that I thought was sort of interesting to navigation because of a really particular patient population. And for us here at Penn Bay and maybe other places, but we seem to get a handful of these patients every year who come from the prison in Warren. And just kind of what that looks like for navigation, because it's just atypical. So we had a patient who came was brought to the ED by the prison for pain, and had a CAT scan of the chest, abdomen, pelvis, and was found to have a large renal mass and hepatic nodules and bilateral pulmonary nodules. So he reached out to Dr. Connolly, who's here, one of our oncologists here, and she just kind of quickly said to him, he needs a biopsy and he'll need to get referred to cancer care, and I'm going to have the navigator call you. So I called him the next day. He was very appreciative. He had already ordered, he thought, a biopsy and sent that over to radiology. I checked with the radiology group. They didn't have anything. They didn't have an order. They didn't know of this patient. So I just took the opportunity to talk with our radiologist, who likes to, protocol what he's going to do if he's going to do a biopsy. He wants to weigh in on the target that he wants and, under what modality he's going to do that. So I had him review the images. He wanted to target the liver under ultrasound. So I was able to call the prison back and speak with their scheduler. She does a lot more than that, but she's the person that we always talk to. And tell her exactly what they needed ordered, and even had a young woman from radiology who schedules ultrasounds under biopsies under ultrasound reach out to them and make sure they had the correct fax number and they knew the wording that they needed to order it properly. So, and just kind of kept following that along. And then found out that radiology still wasn't getting the order, and that was actually being sent over to cancer care. So noticed that it was being faxed to us. So just another point where it was good to have somebody following this, because I was able to take that down to radiology and get that scheduled for him. But it's just an interesting case because it's not a typical case where I could call the patient and talk to him like I normally would about what what's coming up for him and what we're doing and how we're trying to work on this and find out what his concerns are. So we weren't able to do that, but it was a time where it was really important to have someone helping the prison figure out what they needed to do and follow it along. So he eventually had his biopsy, and I just kind of kept checking on it, looking for the path to come in. And when that did, I reached out to them to make sure they had it, and they didn't. So I was able to send that over to them and then follow up on making sure that he got referred to us. And so now he's coming in next week. So just one of those cases where I think it highlights how important it is to have someone following things, a navigator who's working on things and reaching out to the providers. So again, this was a case where it wasn't really navigator to patient at all, but I knew that I was working on his behalf, really, with the providers is what the bulk of the work was, to make sure that things were moving forward for him, because it can be a little slow and cumbersome when we're trying to communicate with the prison and get what we need from them, and they're trying to give us what we need. We can't really force anything along. We can't really push anything. It's just kind of its own world there, and they do things in the time frame that they want to do it. But I think it helped to have someone working on it. So that was an interesting navigation case that I thought of that I thought we could talk about today. Anybody want to weigh in or have any thoughts on it?
This is Carrie, and we've had the same issues with prisoners that come. I can think of 2 head and neck cases, and the pain for a head and neck treatment is horrible, and your hands are really limited. It's difficult to get these patients the care you think that they need, because even getting them to appointments is such a struggle. So I just want to let Kim know we know. I don't know what the answer is. It's very difficult.
Yeah, it is. And the patient hadn't actually been referred to us at that point. I mean, yeah. The doctor from the prison had reached out to Dr. Connolly, and she had given him her recommendations. But at another point during a phone call that I had, they made very clear to us that they would not refer the patient until he had the biopsy, until they knew what the results were. So I mean, we really didn't have care of that patient at that point. But it's a nice opportunity for navigation to just still step in to the gap there and just recognize that someone has to be following this along, because if we don't, then, I mean, maybe it all still would have worked out just fine, but it feels like it had the potential to perhaps go slower than it really should have, or for some things to fall through the cracks, with radiology not quite receiving the order that they needed, and then the prison not having the pathology report. So it's just a good opportunity for navigation to fill in those gaps as we often do.
Yeah.
Does anyone else have questions or have been in similar situations, either for Kim or for Dr. Michalakes?
This is Aisha at Maine Cancer Foundation. It's a question for either of you, but for patient navigators who aren't at larger medical centers, how can they refer patients or access palliative care services if there's not a defined palliative care provider where they work? Because I know you said it was a multidisciplinary team. In Maine, is there a go-to person, even if there's not a palliative care doc or NP or PA?
You don't have to. It's okay. I mean, I think the short answer is probably no. I mean, I guess it depends on if this is a patient who has been seen in Portland for some reason or has been at Maine Medical Center. If you're in a region where there's no palliative care, I guess you just hope they can get a whiff of it as they pass through a larger medical center like, Eastern Maine or Maine Med. I mean, I think since I've been working here, that's what I've been really struck with, is that in your rural areas especially, you really need services like palliative care and navigation, because, very few of our patients can reside in the hospital. We've only got about 50, med surg and SCU beds here at Penn Bay, and Waldo's a critical access hospital. You got to find ways. You have to find ways to get people these supports outside of the hospital. And I don't know what we would do here without Kim. I mean, to me, I've been here both before and after Kim started. And, as we get busier and busier, there's no way we can manage this without navigation. And I think people would say there's no way we can manage this without palliative care. So I think, we do walk step in step, and I think, Kim always knows where to find one of us, either me or Karen. We're always around for the team. So we feel pretty lucky. There's other areas of Maine Health, for example, that just don't have access to palliative care. I think I would love to see us be more sharing and technologically advanced, and start thinking about some telehealth consultations for our colleagues up in Western Maine, for example. So, I mean, I think that's where we need to go.
Thank you. Do folks on the phone have access to palliative care, or does anyone want to share what it looks like in your own health system or hospital or community center?
Hi, this is Heather from MDI. We have a palliative program here at our hospital. It started out as a grant from funders, and it is multidisciplinary. We have an RN, social worker, and a physician. After the first couple years, the model has changed a bit, and it's actually RN-led now. And our physician comes in for consultations on an as-needed basis, and she does office appointments on Wednesdays. But we also do home visits, and we do inpatient visits. So we do try to encompass all of that. Living in such a rural area, it can prove to be difficult, but it's also very necessary because transportation is a big barrier. And when people are so ill and not ready, they don't want to leave their home. So that's been great that our community has been accepting of that. It's still in its infancy, I guess I would say. So we're still learning new things every day. It's only been a couple of years, but it ebbs and flows, and a lot of it is, defining palliative care still, and people understanding the difference between hospice and palliative care, and how it can really benefit people and extend their lives. in a better way. So that's how our model works. We get referral. We're only right now working with patients who have primary care providers through our hospital system. We have the hospital, and then we have, 5 clinics. And we'll also see them from our oncology department as well. So we have a lot, the majority of our patients are oncology, CHS, and COPD.
Thank you for sharing. Are there other questions or just thoughts, or maybe, if anyone else has another case or something that they're grappling with around palliative care, please feel free to share it. You can keep asking. This is Aisha again with another question. I was just wondering, for those of us who don't have access to palliative care services but would like to start a program, or at least bring it to the attention as a need to senior leadership, if either of you were transplanted to another organization, health system, et cetera, where there were no services available, what would be like a practical first step for raising awareness? Do you have any suggestions?
Yeah, I think especially if you're dealing with a cancer population, it's the standard of care, right? If you're not delivering integrated palliative care into the care of patients with advanced cancer, their own national guidelines will suggest that you're not meeting the patient and family need. I think that's really important to point out. I think, when you have national societies advocating for the integration of this type of care into their patient population, I think that's pretty powerful. And the other, going to the C-suite, going to leaderships, it's the value equation. The fact that we now have data that does support the fact that we add quality to the care of patients with multiple diseases, not just cancer, and we do it at a lower cost. We decreased ED visits, we decrease hospitalizations, we decrease readmissions, we keep people at home if that's where they want to be. That's again, that's not the message to deliver to the people out there. It's the message to deliver to leaders who are losing sleep every night with how to pay the bills, right? Especially right now, we're in this in-between phase where we're partially fee-for-service, but we're moving to value-based, medicine. So get on the cutting edge. This is the standard of care, and we can help you, right? I've spoken to enough, leaders over my career, and I've tried to stay away from the whining and the begging, and just really tried to speak to what's most important to an organization. How can we help you? I can help you, right?
Mm-hmm. That's great. Thank you. All right, I'm going to keep asking questions because I find palliative care so interesting. I was wondering, I know that many people on the phone encounter patients who are new Mainers or may not speak English as their first language or have cultural differences. Do you have any resources, particularly for new Mainers, or have you run into this as like a difficulty with, I think palliative care, as you said, is a hard enough concept sometimes to explain to somebody whose English is a first language. So if there's some cultural differences there too, have you had any experiences with that?
Yeah, not so much up here in Rockport and Belfast, but certainly in areas like Portland and Lewiston, you're going to see it. If you're a palliative care clinician, you have issues of religious, cultural, language diversity every day, and you learn who to work with. You learn to structure your approaches. Every culture, every religion is different, and your first task is to try and understand who this person is and what are their beliefs. And you are using members of your clergy, your social contacts, it's another layer of challenges, and we've done we've got some work to do on that front. But your programs that have high populations of immigrant populations are are on that. They should be. I know they are.
Mm-hmm.
Challenging.
Thank you.
Mm-hmm.
Oh. Okay, I just run out of questions. So does anyone else? Anyone else have questions? Or I mean, Heather shared, her experience with their palliative care program, but for folks who might not have one, have you thought of starting one? Would resources be helpful? Is there anything that you do in lieu of having a formal palliative care program?
Oh, I think that's a great comment, because I think that it's sort of like living in a rural area where I don't always have access to a specialty level social worker in palliative care. But you find your clinicians around you, and I'm just guessing that if palliative care wasn't here, Kim, you would find ways to meet the needs through our social work here, through the expertise of other people around you, right?
Yeah, I was just thinking right before she said that if we didn't have Lauren here, which we're so fortunate to have, I'm thinking of our clinical social worker.
Mm-hmm.
She just was the first person who popped into my head. I mean, even though her role is very different than Dr. Michalakes, she has great clinical skills, and she's very used to sitting down with patients and families in sort of a therapeutic session to kind of really get behind how are they doing with this, how are they coping, what help do they need in coping, how is the family doing, what questions do they have, what concerns do they have. So she's talking with patients and families in a much broader sense beyond certainly their disease process to kind of what else is contributing, what's going on with the family dynamic, so she would probably be someone that we tapped here. And we do a lot anyway, but if we didn't have palliative care team here, I think she would be the front line for us.
Yeah, and then there's this this idea that if an organization doesn't have a specialty level palliative care clinician, it probably because there's not that many of us around, to be perfectly honest. And if you wanted to go out and hire a palliative care physician today, it would be challenging. Probably there's not enough. But what an organization might do is to find opportunities to bring in the palliative care skill set into the organization. For example, there are national curriculums, mentioned it in my talk. Serious illness conversation training, vital talk. These are a wealth of information with regard to how do you have these serious conversations about patients in their choices for their care. There's a skilled approach, and so some of our regions in Maine Health, for example, that don't have palliative care, we try and get in there and teach them how to, we teach them what's a post form, what's a serious illness conversation, how, don't say it like that, say it like this, again, trying to find ways to get to this point where we understand what matters most to patients, and therefore how should we navigate. So it's an educational skill set too, that you can't find the person, and maybe you can find the opportunities to educate.
Thank you, that's really helpful.
Hi, this is Barb. Can you hear me? Oh, you can.
Yes.
That was wonderful. Thank you for the presentation, and I love the current conversation. I think it really emphasizes the fact that we all can contribute to helping to assess what patients' goals are, what their families' goals are, and it is a skill that we can attain. And I'd like to be able to try to get my hands around what a training like that would look like, and can we package it and put it out there. I know that there's something that is done for physicians. Is that right? I don't know if there's anything that's available for other staff.
Yeah, I mean, the Serious Illness Conversation Guide was developed by the folks down at MGH, Dana-Farber, Harvard, and it was written as a physician's guide for the oncologists, actually. The palliative care docs working with the oncologist to come up with a guide. So if I'm going to have a conversation with a patient, what must I include? Atul Gawande was involved, the checklist guy. And that particular curriculum, I've studied a lot, I've taught it a lot, used it a lot, but there's some hard parts in there such that I don't think it's interchangeable for all disciplines. I think, part of the hard part of the conversation for physicians is talking about prognosis. So if I have a hard time encouraging my physician colleagues to talk about prognosis in a realistic way, that we don't feel, that's not awkward and feeling like we're robbing people of hope. If I can't teach physicians how to do that, nurses won't. Nurses just, it's not part of what they do. It's not part of their skill set. So the serious illness conversation, the important part for everybody is really exploring what do people understand and then responding to the emotional response that happens, right? Because so much of communication in these conversations, it's not the words, it's dealing with the human reaction. And we are not good at that, right? We physicians are not good at that. Nurses are better at it, right? But they also have a different way of navigating it. So I think, I believe these conversations, I call it a team sport. We all have our role, and especially when you're working in an area like a cancer center, Dr. Conley starts a conversation, and then Lauren will help you with this more, or Kim will help you with the referral to, or this part of the conversation. It's a team sport, and I think that we've spent a lot of time here, actually trying to educate people in the serious illness conversation, because that's what we do when we close the door. There's that one slide that I showed you. So what does a palliative care clinician do? I mean, when we first started here, I could kind of see people were really confused of what does Lauren do when she shuts the door? Because it sounds like they're laughing. It sounds like they're not crying. So what are the elements of palliative care that we can all absorb and respond to? And we all can. I firmly believe that within every single clinician are palliative care skills. We just have to learn how to wake up and use them. And I could help you with a curriculum, Barbara.
Okay, great.
Yep.
You're on. Thank you. Thank you.
Good, and thank you. And it is, we have approached 4 o'clock, so I have to be the timekeeper and bring our discussion to an end. But if you have questions that you weren't able to ask, or if things come up later, feel free to respond to the email thread or send them to me, and I can try my best to make sure that they're answered for you. Tomorrow morning, I'll send out Lauren's slides, some notes from today, and the 2 resources she mentioned, along with the post assessment. So I ask that everyone please take that by next Tuesday, and you'll be entered in for that LOB gift card. So a little enticement there. And our next session will be on November 20th, and we'll be focusing that one on patient empowerment. So if you have a case study, please send it our way. But we'll be in touch with reminders about that as well. So I think that's it. Thank you all for calling in as always and for your great discussion, and we'll see you next month. Thanks, everybody.
Thank you.
Very much.
See ya.
See you next time.